Okay. All right, so this is conditions that are already present at birth. The next one is going to be more like things that happen to babies. But these are things babies are born already experiencing. And there's a list here of the topics that we're going to be covering. So you can see there's quite a few of them in this lesson. SGA, LGA, IUGR, which is intrauterine growth retardation. I should have changed that to restriction. That's what they're calling it now, but I'm old. It's hard for me to remember to say that because I've been saying it this way for 20-some years, okay? So I might slip up, but that should be restriction. Infant of a diabetic mother, post-term babies, preterm. We're going to spend a good bit of time on preterm. And then we get into drug use, both the alcohol and drug abuse. And then newborns at risk for HIV and AIDS, we'll spend a little bit of time on that, not much, and a little bit of time on this last one, the congenital anomalies, because most of those anomalies you studied in pediatrics already. So this is kind of where we're going with this lesson. When we talk about the neonatal mortality risk, realize that we're only talking about the first month when you're talking about neonatal, because we hear a lot about infant mortality. So when you're reading the paper and hearing headlines on the news and things and you're talking about mortality rates, which you do hear a lot about, neonatal just means the first 28 days, and then infant means the first year. So second bullet there is something that we're going to be showing examples of, but the higher the gestational age and the birth weight, the lower the mortality risk. That just makes sense, doesn't it? The longer the baby's in utero and the more he weighs, the more likely he's going to be healthier. So when you put the two negatives together, a low gestational age and a low weight, that's your highest risk people, okay? So infants who have the highest mortality risk are those that are both premature and SGA. So if you're not only premature, you're born early, but you're even smaller than you should be for that premature age, you see why that would be a double whammy, right? So if you're already a 30-weeker and you're the size of a 25-weeker, then you can see that that causes all kinds of problems. So those are compounded. So the risk is predicted when we do neonatal mortality and morbidity is by those two factors, the gestational age and the birth weight. Those are the two biggest indicators. Now I have some statistics on here. You're certainly not going to be tested on statistics, but I want you to get an idea in South Carolina. These are South Carolina kinds of statistics. And honestly, I did not update them. They would have been 1 year. They would have gone up to 2016 probably if I'd have looked them up. But so we're back to 2015. It takes a good while to get the statistics recorded, but this is what we have for 2015. So it breaks it down into the total here, and this rate is what we're always looking at and seeing if we're progressing over the years. So from 2011 to now, we haven't made a whole lot of progress, have we? We went up, actually, 4.6%. And then it breaks it down by race, which really tells you a lot about some of the initiatives that you see in our state. Especially, we have a lot of initiatives. The March of Dimes and some of those organizations are always, trying to make us aware of these rates, and how we compare to other states is really, really bad. We don't look good at all. And I think I have a map on here that shows you that. But when you think about the March of Dimes and some of those other organizations, think about, what they're fighting for. In South Carolina, it's especially important. And we got so much disparity still. Look at this. The white 3.1, well, they lumped all together, black and other, so we don't know how many other, but 7.3. Look at that disparity there. And it's continued every year. Look at that. I mean, we've got some real issues here. So, every state has its issues because there's areas of urban and rural and all kinds of things, so it kind of always confuses me why we're that much different. But it has a lot to do with teenage pregnancy rates, because it very much correlates with that. Infant mortality, which is the whole first year, remember, 405 was the number of actual deaths in just our state, and the rate was 7.0. And look, that number hasn't budged either. And look at the disparity here, 4.8 versus 11.2%. That's just sad. I mean, we've got to do better. And then this one I've tried to color code it a little bit to help you see it better, but I know on your little handout there's in black and white, so you can look at it if you look at it real closely, but it's basically the same thing. Here's that 11.2 versus the 7.0, or I mean the 4.3, I mean. So when the graph, you can see that the pink up here, that's black and other, and then the one in the middle is everybody. No, yeah, the one in the middle is everybody. As you can see over the years, this is way back to 1997, 99. We aren't doing a whole lot to get it down. We're getting down, but not, not enough, not nearly enough. And then this breaks it down by county. South Carolina, this is 2015, and then it goes back farther back in time here. But the total rate here is 28.7 for Calhoun County. And then, let's see, I'm trying to understand why in the world. Let me look at a different one. Okay, so Colleton is 10.4. And then I don't understand why I'm seeing such a big difference. But anyway, see the 20, I was just trying to figure out why 26 versus 9.5 and 4.4 when there were 4 in each one. So I don't know what happened there. Let's see, infant, it's more mortality. Okay. What? Yeah, but I'm talking about the same column on the next, this one versus this one. That 2013, 2015, 2010, 2012. Yeah, I mean, that doesn't, to me, that doesn't hold true. Does that make sense to y'all? Now that I'm looking at it, it doesn't feel right. But anyway, it doesn't matter. I just want you to see that some of these counties, look at, when you get double digits, it's not good. And Orangeburg is terrible. It was that's actually not so bad that time. It was 8%, 11%, and 12%. I think there's a different graph that I'm thinking of that I'll show you in a minute. But this is the whole South Carolina rate overall, so that kind of gives you a comparison. If South Carolina overall is 7.0 and Calhoun is 26, but see, that was just 4 people. But so they just had some very bad outcomes. Let's see where that other one is. Okay, this one is leading causes of infant death, and certainly you don't need to know this. I just wanted to point out that when you're looking at the causes, the total is 405, and of that, the short gestation and low birth weight is the biggest number, the biggest percentage of those deaths. Okay, and we're talking about infants up to a year old. So that's how important this gestational age thing is and this low birth weight thing is. That's what most babies in our state die from. And then it goes down to congenital malformations, and then accidents is pretty high on the list. I was kind of surprised at the SIDS number that would be that high on the list. But there's a lot of them on here, but those I just want to point out. And then leading causes of death by age at death. So this is just how old they are, neonatal versus some of the others. Well, it's actually breaking down the first day of life. Obviously, you're going to lose the most babies that first day if they're premature or whatever, and then less as time goes on. No, I just said you're not responsible for statistics. Okay, 2015 birth statistics. Let's see. I just thought you might be interested in this. It breaks it down, just in case you ever want to look. It actually breaks it down for you how many baby boys were born versus girls. And then we have about 11.9 births per 1,000. The month with the most births was December, and the least was February. Births for teen mothers ages 10 to 19. To me, it seems like they ought to break that down into 2 categories, because there's a big difference between a 10-year-old and a 19-year-old. But it says down here that the youngest mother that year was 12, and then went up to 19. But y'all, look how many, 4,086 in teen births. But I wish they would take that even 17 is, maybe do a 17 to 19 category, because that's a whole different concept than a 14 or 15-year-old even. But I don't know why they lump them all together, really. I mean, they should probably do break it down somewhere, but I don't think that's kind of not a helpful statistic to me, because there might have been only a few of the 12-year-olds, you know. But anyway, 13.5 per 1,000 females ages 10 to 19. So 13.5 in that age category, whereas overall it's only 11.9. So that just tells you this, you know, that statistically there's a lot of teen pregnancies. 52-year-old mom, look at that, yay. Okay, so that just give you an idea of what we, you know, the importance of what we're talking about is why I wanted to just bring those statistics to light. Okay, SGA, you know that means small for gestational age, less than 10%. But remember that this baby might be term, preterm, or postterm. Remember when they come in the emergency room and they weigh whatever they weigh, you might weigh 4 pounds, but that might be a term baby. Okay, not necessarily a preemie. So got to be careful about, hopefully you understand that concept now. An intrauterine growth restriction, we're going to use them synonymously, the two terms, and I said that down here, because there are some differences, but for your purposes you really don't need to know, because intrauterine growth restriction still means a small for gestational age baby. It means they're too small, but it has to do with the cause of why they didn't grow. And we're not going to distinguish between the two. I'm going to call them, I might call them interchangeably, but I mostly call them SGA babies. There is some distinction, but I'm not going to hold you responsible for that. That is a big dog right there. Or either a very small child. Let's look in the book for this section, causes. This is just basically the outline part. Let me set this down for a second. I can't remember what page it was. I have it marked on here somewhere. Page 573. Okay, so let's look through some of these causes. Maternal factors, so they're putting it into the category of IUGR, but as I said, that can be SGA. So maternal factors, make sure that you understand that basically this baby didn't grow for some reason. So most of the time that's going to have something to do with the communication between baby and placenta. So that's the cord, right? So there's either something going on with the placenta itself, or something going on with mom's blood flow, or something going on with that cord. There's something that made this baby not grow, okay? So think about it. It says lack of prenatal care is associated with, as far as maternal factors, age extremes, less than 16 or more than 40. And then towards the end of that little section, it says, before the 3rd trimester, the nutritional supply to the fetus far exceeds its needs. Only in the 3rd trimester are maternal malnutrition and drug abuse limiting factors in fetal growth. Y'all probably already learned that. Did you learn that? That babies can kind of get what they need until that 3rd trimester, pretty much. Going to take from the mother what they need? Yes? So that's what it's getting at, is most of the time you're not going to see a big difference unless there's something dramatic going on with this mom. That baby's going to get what he needs. Up until then, it starts to show up. Okay, maternal disease would be things like sickle cell, heart disease, things like that, but also drug abuse. Preeclampsia is a biggie. Anything to do with the blood pressure is going to affect the blood flow to the baby, right? So preeclampsia, chronic hypertensive vascular disease, advanced diabetes, basically anything that causes diminished blood flow to the uterus, as it says there, thereby decreasing the oxygen delivery to the fetus and minimizing organ growth. So if you just remember it that way, that'll help you to understand SGA. Something happened with this mom that, and we're not always able to identify what that was, but something caused this baby not to get what they needed. Environmental factors, again, they mentioned the alcohol, drugs, nicotine, and then placental factors again, small placenta, infarcted area, abnormal cord insertion, placenta previa. So anything to do with that placenta, really, right? That makes sense. And then fetal factors, these are things that going on with the baby that he's not able to receive the blood correctly or the oxygenation or whatever. So he can have any of those torch infections. Did y'all learn it that way, torch infections? Okay, so any of the torch infections are bad for babies for sure. Any kind of congenital malformations, chromosomal disorders, two-vessel cord, or any of the inborn errors of metabolism. So basically, if baby can't receive the nutrition correctly because of something genetically or whatever is wrong with the baby, it's the same as mom not being able to give it because of something that's going on with her. So this is why prenatal care is the huge push, because, you know, a lot of moms are, you know, especially the ones who've already had a couple of babies, they don't see the importance because they've already done this. We had one this year that had like 6 babies and she didn't get any prenatal care. Who was taking care of her? We had a couple of them actually. We had a couple of gravida 6s and gravida 7s and 8s, and one of them didn't get any prenatal care though. But that's the mother who thinks she's seen it all and done it all. You know, I've had all these babies. I don't have time to pack up these kids and go to the doctor every month and all that. But, you know, every pregnancy is different. And what you don't always feel on your body is high blood pressure. And high blood pressure, it causes placental insufficiency. So that means baby doesn't grow. And if that happened right from the beginning, we got major problems. So it can be very subtle. It's not always something dramatic. Okay, so let's see where we are on those slides first. Okay, let's talk about the difference between symmetric and asymmetric SGA. There's a big difference between the two. There's 2 kinds. The first one, symmetric, means that that the baby's, everything on the baby is small. If you graphed them on the chart, everything would be SGA. So growth failure occurred early in the pregnancy, like the high blood pressure thing, long-term chronic maternal conditions. And that means the baby's has decreased size in general, the weight of the baby's organs. The organs didn't grow, so right from the beginning, because that's when the organs are getting started, right, in the beginning. So even then it didn't start, you know, it wasn't something that happened late in pregnancy. This started right from the beginning, including their head circumference. Now when your head circumference is small, what does that mean? Brain. You think brain didn't grow either. So these are your worst outcomes, of course. If you've got a symmetric SGA, that's much worse than asymmetric. So because of the brain growth thing. So in severe cases, you're going to see that head circumference is affected by it. Asymmetric means the growth failure occurred later. It could be something happened with the placenta, could be cords wrapped around the neck, could be mom's health for some reason suffered towards the end. So baby had already gotten a good start. And so the acute compromise of the uroplacental blood flow for whatever reason. So the only thing that's low is the weight. So bone growth still occurred, especially brain growth. So you see why there'd be such a big discrepancy between symmetric and asymmetric. Okay. Which one's the worst? Symmetric. Okay. All right. So here's what this baby looks like. This would be a typical look for these babies. For the asymmetric at least, because usually their head looks really big for their body. It looks like it doesn't belong on that body, kind of. So small body makes the skull look very large, decreased subcu fat, loose and dry skin. Why do you think the skin would be loose? Because they probably lost weight. You know, they were bigger and now they're smaller, and it's kind of like that a wrinkly kind of appearance. Loose, dry skin, diminished muscle mass, especially over the buttocks and the cheeks, sunken abdomen. You just don't ever want to see a baby whose tummy is not protruding. It should always be protruding, right? We've said that protuberant or protruding tummy is a normal thing as long as it's not tight. This is not normal to see this kind of sunken look. Now, if it was really sunken, then of course we think about the diaphragmatic hernia, where the intestines are in the chest. So that's called scaphoid. But this one is a little bit scaphoid right here. That one looks pretty thin. But so when we see a baby with that kind of abdomen, we're definitely listening real quick for lung sounds and making sure there's not bowel sounds up here. But basically this baby's just really thin. So thin, yellowish, dry, and dull umbilical cord. That's another thing we don't like to see, is a cord that's not nice and fat and juicy. Fat and juicy is good for cords. That means healthy. So when you get you can't really see by these pictures, but the cord looks, it doesn't have any shine to it. You know, when they're first born, the ones y'all have seen are shiny. They look wet and yucky and gooey and stuff, and that's how they should look. But they can be born where it looks like it's a day old already, but the cord's already started to dry out and has that dull appearance. Some of y'all did get to see one baby that we had like this. But anyway, that's not a good thing. And it looks real yellowish looking. Sparse scalp hair, and then wide skull sutures. That's just the bone growth on the head. Okay, complications. The fetal hypoxia is important to understand because it has to do with stress. So if the baby has any kind of stress in utero, then we know that, I don't know if y'all learned this yet, but or maybe you did, how the anal sphincter will relax in utero, and that's when they have the bowel movement. Okay, so if they're hypoxic, it's like, you know, if you can think about somebody being choked, you know, when you have an adult or anybody being choked and they are losing their oxygen, they're panicked, and they may lose control of their bowels, but anyway, it causes a response where the anal sphincter relaxes, and it also causes gasping. So you have a mixture of meconium in the amniotic fluid and a baby who's gasping in utero. So therefore, we end up with all that meconium in the lungs. So when they're born, they take that first breath, all that goes up into the alveoli. So bad thing. Aspiration syndrome. So it doesn't have to be aspiration of meconium always, but at least aspiration of amniotic fluid that wasn't supposed to be in there when they end up being born. So heat loss, definitely that makes sense because they're skinny, right? Heat loss is sort of logical. Hypoglycemia is going to be in almost every one that we talk about because stress uses up your glucose. If baby's stressed and he's chronically stressed, even more so. Hypocalcemia and polycythemia is important to understand here because hypoxia causes the baby to produce more red blood cells. All right, you learned that already? Okay, so hypoxia is going to cause the baby, that's just the normal response to hypoxia, is they start producing more red blood cells. And that's not a good thing for babies. They already have too many. So when they're born, that liver has more of them to deal with. So that's always like a double whammy thing. So polycythemia. So that's your complications of SGA. Let me just go back to this picture again. As far as what I want you to know is I want you to be able to picture these babies. So when I'm asking you test questions, it's going to be, I'm going to describe a baby, and which baby do you think this is, probably, based on the description. So, of course, you don't need to know every single thing, but just get in your mind, why would this baby look a certain way, okay? So it's kind of those general descriptions. So each one we talk about, we're going to talk about the general appearance of the baby. But it's related to the pathophysiology. Okay, outcomes for these babies are, you know, they're varied, of course, but SGA is one of the ones that, besides the preemies, SGA is one of the biggest ones that we follow for a long time to see how they're going to do. Because when you have decreased brain growth, you may not notice a lot of problems with this baby till he gets in school. So you need to follow him for 6 or 7 years at least to see how he's going to do and be ready for early interventions. Because preemies, we automatically do that, but SGA, we haven't always done that. But now we know that those babies are just as important. One of the most fun things I ever did as a nurse was I told y'all I hate ER because in the ED, you don't ever see those people again. You don't know what happened to them after they had all this trauma. So that's what was bothering me in the NICU. Excuse me. We would get so involved with these babies, and then they'd go home, and I didn't know what happened to them. And I would stay in touch with some of the parents, but we had primary patients, so that was our baby. Every time we worked, that was our baby. We had several of them. So you really got to know this family, and when they leave, you just really feel like you wonder how they did. Not just that you miss them, but how are they thriving? And but anyway, I came up with the idea, why can't we go to the clinic and see these patients and see how they're doing a year later, 2 years later, 3 years later, whatever. And they let me do it. We must have had a lot of money back then. I don't know, because they would never get away. I'd never get away with that now. But they actually let me implement it so I could get every primary nurse to get a day, like once every few months, they'd get a day to meet up with their patients, their primary patients who had been discharged a long time ago, and they would be at the clinic, because the clinic is the, I may have done something like this in pediatrics, but I don't think you did, where they go to a follow-up clinic and everybody meets them there. Like they go just for one appointment, and the physical therapist is there, the occupational therapist, the psychologist who does the Denver's really detailed Denver assessments, and the pediatricians. Who else? Everybody that maybe even ophthalmologists, all kinds of people would meet them there, so that mother didn't have 4 or 5 appointments. Everybody was in the same place. So also one of the things they did is they let us sit behind a one-way glass and observe the Denver, which y'all think you know how to do a Denver until you see a psychologist do one. There must be 400 different things they do. I mean, it's just fascinating, because they're looking for real subtle developmental things. But it was really cool because you could watch them interact with the child, and maybe even the parent. Sometimes they would put the parent in the situation to see how it changed, and we as a nurse got to sit behind the panel and not be seen and watch that whole process, and it was really cool. But one of the things we learned was that SGA babies are the ones you worried about the most for the longest, because they really didn't have good outcomes sometimes. And it had a lot to do with what kind of interventions they got and whether people did keep up with their appointments and everything. So that whole process is important. We only see that little window of time where they're babies, but what happens later is so important. The outcomes are listed in your book, but this is basically them in a nutshell. Some of them, for whatever reason, would have congenital malformations and might be the reason they were SGA to begin with. Could have been. Intrauterine infections for sure. And then continued growth difficulties, but especially which ones? The symmetric, right? Especially they would have continued, but even the others have some difficulty catching up with their peers, but especially the symmetric. Learning difficulties, that's one of the things we're following them so long for, is, not just their physical, and speech and things like that, but also their learning abilities and what we need to do to intervene. So their learning outcomes, and I think there was something I wanted to point out in the book about that. It's the only thing I finally have a pocket, and I keep putting my glasses in there. I don't remember what page it is. 574 still. Okay, I was going to point out something. Okay, on 574, under continued growth difficulties there, it says asymmetric IUGR newborns can be expected to catch up in weight and approach their inherited growth potential when given an optimal environment. Environment does have a lot to do with it. At the top of that little bulleted list there, page 574, on the right column, right before those last 4 bullets there, it says newborns who have significant IUGR tend to have a poor prognosis, especially when born before 37 weeks. So that's important to realize. Their outcomes have so much to do with their environment, but there's some of it that really can't be helped even with environment. Yes? No, it might be what caused them to be SGA.
Oh, okay.
Yeah, it might be the other way around. I think that's probably what they meant. Yeah, it wouldn't be true the other way around. Yeah, okay. Yeah, that does say outcomes, so. But let me find my clicker. So just know that we're worried about outcomes with them. The quality of the home environment of the SGA infant predicts developmental outcomes better than any single biological risk factor. So all of the other stuff we do for them physically doesn't seem to have as much impact as whatever environment they are in. So it's so hugely important. I love that picture. That is just sweet. They're both watching TV, I bet. Okay, so anybody have questions about SGA? Okay. LGA, or large for gestational age babies, of course, are greater than 90%. Again, they could be term, preterm, or post-term. They may or may not be the infant of a diabetic mother. That's a whole separate diagnosis. But we sort of treat everybody as if they are an infant of a diabetic mother until we prove they're not. In other words, when we get a baby that's greater than 90 percentile, we are going to get a blood sugar, because maybe the mother's undiagnosed. Many people who are diabetic just didn't catch they didn't get screened at the right time, but they actually were diabetic, or at least pre-diabetic. So big baby, you automatically start thinking, we got to get a blood sugar. This was not always the case, and this is why it's important, because before they knew this, used to be the bigger your baby, the better. Remember, the old folks used to think, you needed a fat baby. If you had a fat baby, you did good. You needed a good fat baby, strong baby that's, babies that were big were strong and healthy. And that had really bad outcomes a few times before we realized this cycle that the blood sugar was going through, where the 2 hours, where we check it in 2 hours. So they'd have a big baby and they wouldn't worry about them, bless you. And those babies died. I mean, they could actually just die because you let their blood glucose go down to nothing. Because you can check some of those babies with low blood sugars and they'll be like 20 blood sugars. I've had 18, 17s on their blood sugars, and they're big babies. So what would we have done if we hadn't checked it? And they didn't eat. They don't tend to eat real well either. They tend to be sluggish babies, these diabetic babies. So now that we know how bad the outcome could be, we just treat everybody like one until we prove otherwise. That's my point. So every LGA baby gets treated like he's the baby of a diabetic mother until we get a good blood sugar. So if he really is the infant of a diabetic mother, only his weight is greater than 90. His whole body isn't. In other words, his whole body wasn't fed insulin since day one. Fed too much glucose, the whole pregnancy. So he didn't get fat all over. He's just big on his weight. I'll explain that more when we get to the next one. So the other LGA babies, the weight, length, and the head are greater than 90%. Okay. This is my LGA teenager. That was Ryan when he was 9th grade. He makes me look small. I look petite, don't I? That's about the only time. But anyway, my point is, the reason I even put him in here, he was an LGA baby, and I wasn't diabetic. So sometimes you don't know what the child's genetic makeup is. But I married a bishop. They're all huge, okay? And I kind of knew that was going to probably happen, but my daughter was 6 pounds, and she remained very small, normal-sized person. Thank goodness it wasn't the reverse, but he was 9'1". So first one was 6. He was 9. But that's what my point is, that sometimes you don't know at the time of birth if your baby's going to be a big person or not. Because lots of little babies turn out to be big people, and vice versa. You get big babies that end up being small people. But in his case, he just got bigger. This was college. And, he's just a big guy, and he was destined to be. So some babies are born big because that's who they're going to be. And it's not because they're diabetic or anything else or any problem. But it's just not, you can't know that at the time of delivery. Isn't he precious? Yeah. Yeah, well, I don't think he's bigger than that. He's probably maybe a little bit, but his wife keeps him on a strict diet. Oh, my gosh. When I go over there to babysit, I have to take my own food with me because everything in the refrigerator is like spinach, broccoli, asparagus. If it's not green, it's not in the refrigerator. They don't even have mayonnaise, so I have to take my own condiments and everything. But I should eat with them instead of going against the grain. But she keeps him on a pretty tight leash, and he still deals with his weight issues. But he also got thyroid issues too. He got major problems with that. He takes medication for. So, but anyway, regardless, he's a bishop, and so he can't help some of it. Okay, this is a student brought me this picture one year, and I love this because we were studying LGA, and she brought me this picture of her and her friend, because this baby here was 6 weeks old, and this was 10. So you know this one should be bigger, but he shouldn't be that much bigger. He's only 4 weeks different. He looks like he's going to eat the other one or something, you know. I mean, doesn't he? He just looks like a different type of being. I don't know. But that's a really good example. So when we were studying this, she brought me this picture. She said that she and her friend had been talking about what a big difference, you know. And that's a great example because he was LGA. And then this is some of the causes of LGA, other than the infant of a diabetic mother. Pre-pregnancy weight seems to have something to do with it if the person tended to be overweight before they got pregnant. Even though those are the people who don't look like they gain much weight, they sometimes still have a big baby. And then pregnancy weight gain itself, how much they've gained during the pregnancy. Multiparous moms tend to have bigger babies. Males tend to be bigger babies. And then there's some syndromes and abnormality type things that can cause LGA too. Erythroblastosis fetalis, we're going to learn about that one in the next chapter. And then that Beckwith-Wiedemann syndrome, y'all remember that one in pediatrics? That's the one where they got the big tongue, all their organs are big. It's a autosomal, I think, dominant disorder. But it's the child has a big tongue, but all the organs are enlarged as well, so it causes a lot of problems for them. Transposition of the great vessels is another one. So there can be some abnormalities that cause the LGA, but could also just be the mom's eating habits or her genetic makeup. Complications, of course, birth trauma makes sense because we've got to get that big baby out somehow, and sometimes the act of getting them out causes the problems, doesn't it? So that's why we have fractured clavicles, Erb's palsy, facial paralysis, even skull fractures sometimes, cephalhematoma, and intracranial hemorrhage. More likely to have a C-section to be able to get the baby out because it's just a big baby. More likely to have to be induced, and that's probably because it's not time yet. The mom's got a lot of weight gain and she's ready to have this baby really, but she's not going into labor because she's not 40 weeks yet, you know, but she needs to have the baby because they know the baby's getting really, really big. So sometimes they would end up more likely to try to induce those births. Hypoglycemia, of course, polycythemia. Polycythemia is a real big problem for these babies, and that's why this baby's so red. They have way too many red blood cells, and they are known to be polycythemic. And those big red, you know, those having that many and all that fat and all of that combined causes them to look really red, and they actually look very healthy because they're so pink. Everybody keeps saying, oh, he's so pink and pretty, he's so healthy. He's fat and pink. Well, that's not good. And then hyperviscosity as well because of the high number of red blood cells. It's thick. It's thick blood, you know, and that can cause issues with perfusion. The blood doesn't flow real well. So I hope y'all are kind of putting it together as to why things happen, and then it's not like memorizing, it's more like understanding it, and then you can see the symptoms that are caused by those same things. Now this is what you call a big baby. That's a good picture for IDM. So they have increased body fat. That is not water weight gain right there. No, that is fat. And that baby's not going to lose that easily. So it's not going to be like a thing where you see a lot of really big babies, but they can lose a lot of weight in the next few days because they're just so edematous. This is not edema. They're macrosomic, large weight and body size, ruddy due to the polycythemia. All that redness in the cheeks here and all across the body, that's what that is. Large umbilical cord and placenta. And I did say that juicy cord is good, but there can be an extreme on that as well that's not good. They're not edematous, has decreased body water, if anything. Increased weight of all his organs except his brain. So if your liver weighs more, your kidneys weigh more, everything in your body, your pancreas, everything weighs more, then that's a lot different than just being fat. Immature physiologic function. So these are babies who don't do well. They they look very big and mature, but their lungs don't mature very well, and they don't tend to, none of their organs function correctly because of this issue. They can have many complications, and like I say, these babies unrecognized will not survive sometimes. Hypoglycemia, and for us that's going to be defined as less than 45. I'm not going to trick you with the 45, 46 thing, because over there they use less than 46, but I would tell you something, not 45 or 46. I would go way over or way under so that you would know. Hypocalcemia again, hyperbilirubinemia, big problem because of all the red blood cells, right? Birth trauma, polycythemia, respiratory distress syndrome, because actually their lungs are not mature. There's something about that exposure to the glucose that inhibits the lung maturity, even though it's increasing everything else in cell numbers. Congenital birth defects can be associated with it as well. Okay, so y'all following me so far? Okay, so the treatment, of course, we got to get a blood sugar, and we got to find out if this baby's okay with his glucose. We know he's probably okay right at first, right? Because he's still got the influence of mama's glucose and his insulin. But now he's going to keep on pumping out all that insulin, but he's going to run out of glucose. And that's when we run into trouble. So blood sugar every 3 to 4 hours. So when we know the mom really was diabetic, even if the first blood sugar is normal, we're going to keep checking. So if we have a documented case of gestational diabetes or any kind of diabetic, then we would keep on checking them even if they're normal at first. But when we're just suspecting it because of size, we just do one. And if it's normal, we don't keep checking it, if it's just the LGA baby. But this baby really has a documented mom with diabetes. So we're going to keep on checking them for at least the first 24 hours. And they do preprandials. Those can be tricky when you've got breastfeeders, too, who sometimes really have trouble getting that timing right. But it still seems to be a good enough screening tool to identify problems. If it's less than 45, we've got to do something about getting the glucose in there, right? So if he can eat, we're going to feed him, formula or breast. So early feeding is the cure for this. Early feeding, you just give them something to eat. But if they can't eat because they're sick, might be on the ventilator, they might be on oxygen, might have a really high respiratory rate, whatever, you still got to get some glucose in them somehow. So we're going to start some D10W. We never give D25 or D50 to babies, because they do have that rebound hypoglycemia with that. I know they do that with adults some, but you don't ever do that with babies. It's always going to be D5 or D10. Okay, any questions about LGA or IDM? Making sense? Okay. Do you want to take a break before we go on, or are we good? I can't remember what time we started. I'm going to try to watch the clock today. I can't remember what time we started back. Well, it has been about an hour because we started back about 10 till, I think. Okay, so let's take a break. 10 minutes. Okay, I'm going to go back a couple of slides here to show you something I just realized I didn't mention. Well, that's not it. I think it was this one. So listen up, guys. Shh. All right, so I just meant to mention that if this mom was a severe diabetic, she might have an SGA baby. So every now and then you will see a diabetic mom who will have a very small baby, but that would be unusual. I just thought I'd throw that in there. But, you know, when they just have regular gestational diabetes or they're poorly controlled diabetes or whatever, they tend to have these babies. And what else was it? I think that's okay. We'll cover that part later. And just that with the right interventions with this infant of a diabetic mom, now that they are very aware of it, even in the early pregnancy, they're screening for diabetes so carefully, these babies do tend to have very good outcomes if everything is controlled and they're monitored and all that. Okay, so it was just in the old days when they had the bad outcomes, when we weren't watching all that. Okay, so postmature syndrome is, the postmature syndrome is different than just postmature. You know how a lot of things we talk about that it could happen. So most babies actually don't have the syndrome. But if they have the actual syndrome, then it can be pretty bad. So postmaturity syndrome would happen at greater than 42 weeks gestation, and it means they also have the signs of postmaturity. So you can be greater than 42 weeks and not have postmaturity syndrome. Okay, you get it? So only 5%. Pardon me? Not in the book. The whole postmaturity thing not in the book? Oh. Okay. So only 5% of postterm infants have the syndrome. So increased mortality rate in postmature fetus and the neonate, 2 to 3 times in the mortality rate, y'all. So this is why nurses who know anything about this syndrome and have seen it, when they themselves are pregnant, they are very nervous to have their babies at 40 weeks. They don't want to go past 40 weeks because you can have some very healthy pregnancies that were fine if they delivered on time, but they went too long and they have very poor outcomes if they have the syndrome for sure. So very bad outcomes. Postmature placenta. Apparently that placenta is only supposed to function for 40 weeks, and 42 is pushing it way too far because then it just kind of stops doing its job. Inadequate gas exchange and nutritional support resulting in fetal asphyxia and hypoglycemia to the very high degree. Intrauterine hypoxia often results in passage of meconium. So these are the babies that are really well known for the meconium aspiration thing. Because they are going to be very stressed and they're going to definitely have the meconium issue and the gasping and all that. So when I talk about postmaturity, I'm going to be describing the syndrome kind of kid, okay? So I know that doesn't happen to all postmature babies, but when we're learning about it, we're going to learn about the extremes here and kind of have a picture in our mind of what this kind of baby would look like. So here's the characteristics. Long, thin body. And that small body makes the skull look very large, just like that SGA baby did. Dry, cracked, I can't say that word, parchment-like skin. So why would the skin be all dry and cracky and all? And what happens when you sit in the bathtub too long? Your skin gets all wrinkly and dried up, and when you get out, you're all... So anyway, just think about it. He was in there too long, okay? So but they get that parchment skin. You can't see it real well on this, but if you had it on your computer in front of you, you probably could see it better. But that's that kind of skin I was talking about, this parchment. When you touch it, it has like this look of like wax paper, like the wrinkles just kind of spread out from where you touch it. Okay, that's parchment-like. If you're a cook, you know what parchment paper is. But that's why they gave it that name. So it's a really dry skin. And then the hard nails that go beyond the fingertips, because they've just been growing and growing. Can't really see it real well on that picture because it's so small. Profuse scalp hair, depleted sub-Q fat, loose skin or old person appearance. These babies are the ones that are really known for the loose skin because they really did lose weight probably. They were probably healthy at 40 weeks and then they didn't get good blood flow, and so they are literally losing weight at the end and their skin's more baggy looking and wrinkly. So they say old person appearance. Absent vernix and lanugo. Often meconium stains, so their skin and their umbilical cord, their nails, everything looks green like meconium, has that greenish kind of tint to it. At least if they did have the meconium aspiration or the meconium in the fluid. Okay, so the way that they behave is they're often born looking like, I think about this as the person who's drowning. If you saw a person who's drowning and gasping for help and they just keep going under, and what would they look like? What would their eyes look like? They'd be wide open eyes and they'd be like panicked. They're really panicked. And it's almost like these babies are born like that, like, whew, you know, I'm finally out of there. Somebody saved me. And they have that wide-eyed look about them. I know that sounds terrible. Sounds funny, but it's really not. Often alert, wide-eyed appearance from chronic intrauterine hypoxia. So this has been going on for a little bit, at least those couple of weeks, right? Or however long they are post-term. Characterized by prolonged pregnancy, placental aging, placental insufficiency, and prolonged exposure to amniotic fluid. Complications, definitely hypoglycemia. Meconium aspiration is classic for these babies. Polycythemia, again, because of stress. Okay. Congenital anomalies could have been an issue to begin with. And then that can cause seizures, because you can have seizures just from the hypoglycemia and hypocalcemia and all that too, and from stress. And then cold stress because of the low sub-Q fat. Some relaxed doggies right there. The recliner. Okay, the way we treat, of course, we're going to make sure the baby's okay, vital sign-wise, and you know, we've got to make sure that he's not asphyxiated at birth, but if he is, we're going to treat that, of course, and then we're going to continue to monitor him closely because he's very high risk for asphyxia. Keep him warm, monitor his blood sugar, of course, which we're going to do for everybody that's in any kind of stress. Feed him early. Feeding early treats a lot of problems. If they're not breathing too fast, they're not in any other kind of stress, there's no contraindications, they should be fed. So feed early, formula or breast. If the blood sugar is less than 45 and they are too sick to eat, we're going to do what? Start an IV, that's right. That just makes sense. Monitor hematocrit for the polycythemia, and then a lot of times these babies will end up on oxygen because they have been, think about it, if they've been in chronic hypoxia at birth, they're ready for some intervention usually. So if they really do have the syndrome, they're really sick. And as I said, the mortality rate is high. So, okay, that's what we're going to do now is move on to preterm babies, and I have a video to show you. So I think our timing is going to be good. I have less time to teach this unit this year than I usually do, so I'm trying to pace myself. And I almost did away with the video, but I think it's well worth seeing, and I think it'll help you to understand when we start talking about preemies. So I'm going to turn this off now. Okay.